The scapula plays many roles in shoulder and arm function. One of the main ones, it's a key component of scapulohumeral rhythm, the coupled motions of the scapula and the humerus to allow normal arm function. It also is a mobile but stable platform to optimize glenohumeral joint function throughout the full range of shoulder motion. It also provides a congruent socket so that it maximizes glenohumeral dynamic ball and socket kinematics, which then facilitates glenohumeral joint concavity compression. This video illustrates the ball and socket arrangement to make sure that the ball stays on the sea lion's nose. Other scapular roles include being a stable base for all the muscles that attach, the 17 muscles that attach to the scapula. It also facilitates activation and in the full ranges of motion from retraction to protraction. It also allows for acromial elevation. So as you move your arm, there's no impingement. Finally, it is a link in the kinetic chain, the coupled motion from the foot to the hand of force generation and force production. If you do have these optimal scapular kinematics, then you have optimal shoulder and arm function. This schematic shows the flow of energy from the foot to the hand, with the scapula being a key link in the middle of the kinetic chain. The normal 3D kinematics has two translations, one of superior-inferior translation and one of medial-lateral translation, and three motions: upward-downward rotation, anterior-posterior tilt, and internal-external rotation. Actually, these motions are not ever just individual. They are coupled, as this video shows, so that all three are going on at the same time to allow the most correct position of the arm as it moves to do the activities in three-dimensional space. Normal mechanics mean that we get control of the motion of the scapula on the thorax so that it allows the optimum position, which is mainly retraction and external rotation, as a base of stability. This also maximizes the muscle force couples, which create the dynamic stability around the scapula and the glenohumeral joint. Finally, it allows maximal muscle activation so we can develop the most power and strength in the arm. This slide shows the retraction, which is a coupling of external rotation, posterior tilt, and upward rotation. The results of the control of the mechanics is that we get acromial elevation, we get maximum forward flexion and overhead rotator cuff strength, and we have a glenoid that is what we call retro-tilted, which is in the right position to avoid internal impingement. Scapular dyskinesis is defined as an alteration, dys, of kinesis, which is motion or position. Scapular dyskinesis is not a musculoskeletal diagnosis, and it's not an injury by itself. It actually may be an asymptomatic finding. However, it's very, very commonly involved in association with shoulder and arm problems, and when found associated with these symptoms, it needs to be addressed both in evaluation and in treatment. Dyskinesis is really best thought of as an impairment of optimal scapular kinematics. It has the potential to affect the scapular rolls to create or exacerbate the symptoms that the athlete or the worker has. There are multiple positive causative factors for this observed alteration of kinematics. Remember that the bad thing about scapular dyskinesis is the opposite of retraction, which is protraction. Protraction is a combination of increased anterior tilt, increased internal rotation, and decreased upward rotation. Scapular dyskinesis is really a clinical observation. This patient is shown to have the observed alteration of position and motion. It shows medial border prominence, and it shows the protraction that exists. This video very well illustrates the difference between kinesis, or normal, and dyskinesis, abnormal motion, as the arms are taken in overhead position. It's quite obvious that the inferior medial border of the scapula becomes prominent and is the hallmark of the observation of scapular dyskinesis. The scapular exam is really a very comprehensive exam. It involves a stepwise, comprehensive program so that you really get the entire understanding of the entire body and the kinetic chain. You can usually use screening tests and maneuvers to identify the entire body, and then spend some time looking at specific areas that are shown to be deficient on the screening exam. You can use objective measurements to actually measure some of this range of motion and strength. Remember that you need to not only evaluate for the pathoanatomy, the actual anatomic injury, but also the pathophysiology, which is the alteration of muscle strength, flexibility, and activation, which very commonly accompanies this problem. There are three components or steps to the exam. Number one, you have to establish the presence or absence of the dyskinesis. Usually we do this by qualitative bio-observation if dyskinesis is present. Second component is the effect of the dyskinesis on the clinical symptoms and the clinical presentation, how it affects the symptoms. And then the third part is to assess the different causative factors for the dyskinesis, what causes the problem. This clinical pathway demonstrates the three steps to complete the comprehensive exam. We will spend the rest of the time now on the exam illustrating the part 3, how we evaluate the causative factors. When we get through this, we will have a comprehensive understanding of the problems that are associated with scapular dyskinesis and use this as a guideline for initiating treatment. This patient has had a history of problems in his left shoulder for about 2 months following a traumatic injury. He's had trouble with forward flexion, overhead position, and pain in the arm. So we'll start in the exam from the ground up. We'll look at the ability of the hip and core to maintain stability. So Zach, what I want you to do is to stand with all your weight on your right leg, raise that up off the ground. Now do about a half squat down for me and back up. Back up. And do the same thing with the left leg. That's good. And you see there's some loss of control of the hips there, indicating that probably the core is a little bit weak, and we can start there with some of the exercises we want to do. The next is we're going to look and see how well he does to retract the scapula back voluntarily. So Zach, I want you to just pull your shoulder blades like you're pinching them together. So he does this pretty well. Okay, that's fine. Now we do a maneuver called the low row. This is where we want to see how well he can pull his scapula back. So Zach, I want you to push with your hand just straight back against my hand. That's good. And we do this bilaterally, so push back here for me now. Okay, I think you see that the right side stays very nicely. Now, do you feel like there's any weakness on this left side? Push again for me now. So you can do it. It takes a little bit more effort. Now, one of the corrective maneuvers is to actually have them tighten up their hip and core to see if that makes it any better. So now I want you to tighten up your hip muscles real good. Now push back here for me now. And it's a lot stronger, and you see it stays better. So facilitating scapular retraction with hip control is going to be another one of the things we're going to be looking for. The next is called the scapular dyskinesis test. We're actually going to have him raise his arms overhead 3 times, just normal forward flexion, and we're going to watch the border of the scapula to see how it responds to this challenge. So like just 3 times, take your arm straight up overhead and all the way back down. And just watch the movement. You see the obvious loss of control. Do that again. Loss of control of the inferior medial border of the scapula there, with this whole area being very, very prominent. Okay, one more time. And you see this side right here, upper trap, is a little bit active as well. So you see the obvious asymmetry of the scapula. So that's a positive type 1 scapular dyskinesis. One of the things we can do from here is to do the corrective maneuvers. One is called the scapular assistance test, where we actually assist the motion to see if we can make this work better for improving the motion and improving the smoothness of motion and getting rid of some of the pain. The way you do this is you take one hand and put it along the inferior medial border of the scapula, put the other one up here to kind of guide this, and you're actually guiding, assisting the scapula not pushing, just assisting as he comes up. So now, Zach, take that arm up overhead for me now. And back down. You see that the observation is that the scapula stays. Now, the subjective, you say, how does that feel? Does it make it feel any better? It feels more normal. You say more normal pattern because we're correcting that particular maneuver. Now, the second thing we do here is to test the scapular control against applied resistance. So we're going to actually come out here. Now, Zach, I want you to push out against me here now. You see the obvious winging right there. Okay, and the second is to bring your arm into this position here. Now, hold it here. Don't let me push down. How's that? Does that feel sore or painful? All right, bring it back down. So now the second test is the scapular retraction test. This is where you mobilize the scapula into a retracted position and actually hold it in that position with your forearm to see if it changes any of the symptoms. The way you do that is you manually place the arm here, put your forearm right across the medial border of the scapula. Now repeat the same thing. So push out for me here now. So he develops more strength. You actually about 20% more strength with the scapula stabilized. And once again, take your arm out here. I'm going to push down, hold it there. And is that feeling stronger? Feels stronger. Actually, our studies show it's about 15 to 20% more forward flexion strength by doing that. So we've kind of mapped out a few things that are going on here with the scapula that affect his clinical performance. The next thing we're going to do is just to look and see, shrug your shoulders up for me now. Hold them up there real good. Now, does that bother you to do that at all? That doesn't hurt. Does it feel any stronger or weaker on either side? No. So it's pretty good with that right there. All right, so that's what we want to see. Now we'll do one more thing. We're going to look at the glenohumeral joint because sometimes that will play a role in the scapular dyskinesis. We mainly look at internal derangement and range of motion. So we'll take the arm out in this position here. We'll just have him come down in internal rotation. And then we compare it to the opposite side, all the way down. We do both of them. And they're actually pretty good. So there's really not, at this point in time, there's not a whole lot of range of motion problems with this glenohumeral joint. We also look at the internal derangement, mainly the test called the MDLS, which is a good test for labral pathology. We'll take his arm in this position here. Pull it back. Does that bother you at all there? So there's no history of this, but you always want to rule that out because that's a major problem with scapular dyskinesis. So now you see we've screened the exam pretty well for almost all of the common factors that go along with scapular dyskinesis. Now I'd like to introduce Dr. Aaron Shasha, one of my colleagues who's been with us many years on the scapular investigations, and I'd like him to demonstrate some of his parts of the exam in terms of how you assess posture.
Hi everyone, my name is Aaron Shasha. I am the director of the Institute of Clinical Outcomes and Research for Lexington Clinic. Today, for this part of the examination, we are going to begin with the observational components, primarily looking at posture, but we'll also look at scapular asymmetry as well as muscle atrophy. And so where we will begin with the exam in the postural component, we need to understand that there are numerous techniques out there to try to quantify posture. The concern, however, is that although these techniques have been shown to have a decent level of reliability, there's not one standardized method that we tend to go with. So we're going to go more of the traditional route, which is going to be more of the qualitative approach. So we're going to just use our eyes to see if we pick up any deviations from what we would consider anatomic normal. So we'll begin the exam with the patient in the lateral position. And so we're just going to make note from the head down exactly what we believe we're seeing. And so if we begin at the head in the traditional method, assuming we had a plumb line going through the midline of the body, we can see we have a little bit of a forward head type of positioning. However, as we get further down, we see in the shoulder, we seem to straighten out. And as we go further down, we don't seem to have too many deviations going away from that midline. So in this case, we would say we would have forward head posture. That's probably about all. But the other things we're going to look for would include spinal anatomy or spinal abnormalities for that matter. And so we will look at any type of kyphosis or any type of lordosis in this position, which we don't seem to have any going on in this particular case. And so once we've identified those issues, now we're going to actually do another set of observations, just doing from the posterior view. So in this position, now we can make note of a few more areas. Do you see alteration in shoulder height? Well, we know he has his involved side being his left side, and so we see a little bit of depression, but we're not sure if that actually means anything to us just yet. Later in the exam, hopefully other pieces will pull together and we'll know if that's actually a true abnormality. We're also going to look for scoliosis type of situations. So we're not going to do a full scoliosis exam here today, but this is the part of the examination where you would do that, seeing if you have any type of right or left thoracic or lumbar directed curves. Moving forward now, we're going to look at scapular asymmetry. And so what we're going to look at here are the prominent borders that tend to be very pronounced to us in regards to the scapular positioning. And so we look for the medial border, which we see actually on both sides are very well pronounced. The inferior angles, which are pronounced as well. And in this position, we could actually determine if we see angulation or some type of internal rotation or tilt, which we see, this appears on the left side, which is his involved side, to be more vertical or more straight up and down. And on his non-involved side, maybe a little bit of angulation, but not anything too concerning at this point. And then finally, the last part that we're going to look for are any obvious atrophy situations. So we look at the key areas. We look at the superior aspect of the shoulder. We look in the over the body of the scapula itself, over the infraspinous fossa, as well as any possibility of atrophy over the rhomboid area. And in this particular case, we don't tend to see too much. There's a little bit of a depression here in the infraspinous fossa, so there is some possible atrophy. But again, this part of the exam is not very specific. We're just trying to pick up things that might be of relevance. And down the road, hopefully the rest of the exam will be able to pull together and we can have more of a solid answer.
Now I'd like to introduce Dr. Tim Uhl, my long-standing colleague who's been working with us on the scapula problem for about 30 years. He's going to go over the areas for palpation, for understanding the hands-on component of the exam.
My name is Tim Uhl. I'm a professor in the Department of Physical Therapy. I'm going to go over palpation associated with a scapular assessment or shoulder assessment. So we're going to take a look at Zach. Zach's a nice, thin individual, so it's relatively easy to find bony palpations. First thing I want to look at is the clavicle. I'm going to focus just on his left shoulder. I would do this bilaterally. So as I palpate out laterally, the first thing you're going to tend to focus on is over here on the coracoid process and see how tender that is. Does that bother you and I poke on you? So the coracoid is attached with the pectoralis minor. Are you sore at all in there?
No.
Not too bad with that. So the short head of the biceps and the coracobrachialis come over laterally. So I'm going to work all the way out to the end of the clavicle over to the acromion. I'm going to have him bend his elbow and just externally rotate a little bit and just relax. Let me hold it there. I do that so I can palpate the biceps tendon a little easier. Any tenderness in the bicep?
Just a little.
A little bit tenderness over there. That's pretty common to have, especially after you fall down and go boom. All right, let me have you rotate just halfway there. Any tenderness along there? Doesn't look like you have any deltoid and you can feel this okay, fine? Perfect. How about up in your upper trap? Has that been bugging you? Your neck a little bit? Looks like you were having some sort of substitution. You more sore here or more up closer to the neck?
Probably closer to you.
More up in here. How about back here? All right, so that's more levator versus upper trap. He's a little tender in both as we go up through that. As I walk out here laterally on the spinous, or medially on the spinous process, I want to get to the medial border, see if he has any trigger points or tenderness. Rhomboid's a little fired up there. You jumped a little there. So a little sore in the middle trap, and rhomboids, anything down here? A little bit sore. So he's sore all the way down into his lower trap. Find the inferior angle, and then I'm going to poke around here in his infraspinatus. Any tenderness, any referred pain there?
Nothing.
Something's there. You got a few knots in there. Do you have any pain going down your arm when I poke on that?
No.
So it's pretty common sometimes with infraspinatus tenderness after a trauma. He's probably going to be a little tight. Doesn't look like he was too bad, but that can give him referred pain, different than radicular pain. So since Zach had a little bit of a trauma, we want to make sure his shoulder pain didn't come in from his neck. So I'm going to have you go through a few motions here. You tell me if any of this bothers your neck or gives you any symptoms into your shoulder. So look over to your right for me as far as you can. Good. Does that bother you?
Nope.
Good. Look as far as you can to the left. Good. A little harder to go to the left. Any pain with that?
Nope.
Good. Side bend to the right. Nope. Side bend. Ear to shoulder.
Oh.
There you go. There you go. That's it. Any pain with that?
No.
Just a stretch maybe on that side?
Mm-hmm.
Good. And then to the opposite side. Good. A little definitely tighten his upper traps when he goes over that way. Good. So, any numbness or tingling down your arms or anything like that? Good. I'm just going to push on your head just a little bit and see if that makes your symptoms getting worse. Any change in symptoms?
Nope.
So, I'm applying about 20 pounds of force. Relax. Now, I'm just going to gently distract your neck. Any pain or symptoms with that?
Nope.
Good. So, lean your head to the side. There you go. And now I'm going to do a Sperling's test. Just push you straight down. Any symptoms with that?
Some up here. Just
A little bit of a stretch. Okay. Nothing going down your arm?
No.
Good. And then straight over here, just side bend over. You are tight in your neck.
Mm-hmm.
How about on that side?
Nope.
All right.
The results of this exam show many of the deficits and alterations that are normally seen in patients with scapular dyskinesis associated with shoulder pain. They include hip and core weakness and instability, loss of scapular retraction control that is improved by hip strength, pain along the medial border of the scapula in the rhomboids associated with trigger points, impingement with forward flexion that is relieved by scapular assistance, weakness of shoulder external rotation and forward flexion that is improved by scapular retraction, pain and soreness and trigger points in the neck muscles, all of which can lead to the problems with scapular dyskinesis. However, the screening exam also shows that there's no anatomic problems such as cervical radiculopathy, glenohumeral joint internal derangement, or bony problems. The exam also shows that some of the more chronic problems that can be associated with scapular dyskinesis are not present in this acute case. As a result, all of these can be used to determine a good kinetic chain-based rehabilitation program that can be started to improve the deficits. Each of these points will be discussed in some detail in future sessions of this video series. My colleagues and I have really had a good time putting these together. Hopefully you all will have enjoyed this part of the series, and if you want to see the entire video and others in the series, they will be available at www.kiblerscapulasessions.com. Thank you very much for your interest, and have a good day.